Okay, so let's begin. Case 1, you all can see, I assume, right? Patient who is relatively young, 56, 180 pounds, 250 pounds, and right knee had a sports injury when he was young, and he got this deformity. So patient has a varus and a flexion contracture of 15-15 in both plane. So I like to start, and I'll do this, I'll start one time from the end, other time from this end, and third time in the middle. So everybody gets an equal opportunity to express. So I'll start from the clockwise, which will be the right. So Ted, tell us what kind of knee would you choose? This guy played tennis all his life until last 5-6 years. So what kind of knee and why?
Okay, well, I would start off by saying that I think the technical factors here are going to be, in terms of addressing the varus deformity and the flexion contracture, will be more important to this patient than the type of knee we choose. But a couple points. I would choose a posterior stabilized knee because of his flexion contracture and deformity, and I think the track record there is quite predictable. I think what you're getting at here with this case that makes it interesting is at 56, he's a high-demand user, and he's going to be at risk for polyethylene wear. It's going to be over the long term. That's going to be the problem. And so the implant choice might be directed at minimizing that, and I think it would mean potentially a monoblock non-modular component, or if you're a believer in a mobile bearing, potentially a mobile bearing component. But this patient's long-term issue is going to be wear, and that would be relevant to the implant choice.
Yes. Dr. Banerjee, tell us what kind of knee and why your position.
This is a high-demand patient, and obviously requires a good range of movement, and I would choose a knee which will last him a little longer than usual. And I would
I think I have a advice to all of you because I have so many cases. So to the point, and I don't need a long explanation. I'll use this. That's the kind of answer I'm looking.
I'll use an RPF knee.
Okay, so you will use RPF knee, and reason for?
It's got a better chance of a longevity, and it's got a good range of movement so that he can pursue his sporting activities.
All right. Okay, anybody on the panel wants to use a cruciate saving knee? Any taker? No. All right. So biplane deformity in a male and relatively young and active patient, you want to do a knee which can correct his deformity, one, and two, you will be concerned for wear and fixation in the long run. Would any one of you will discourage him from playing singles tennis if he get a good outcome? Okay, so
can I encourage him to play doubles?
You can always encourage him to play doubles.
Yeah, so that's, in answer to your question, I would try to steer him a little bit less towards that, having to go back and forth laterally in the singles, but doubles to get the same exercise.
Yeah, I have done that kind of survey, both on hip and knee, And this is the summary of the survey on a patient-administered questionnaire on sporting activity. That 10% of the knees and 15% of the hip were jogging, if they get a good outcome. And whatever you tell them, they nod their head, yes, 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 but they do it whatever they can do. So if he can play single, he will play, no matter how much do we say that don't.
But that doesn't mean you would necessarily...
No, understand.
Right.
But I'm just saying, one is the reality and other is our advice. That's the point. Okay. So here is patient got a RP, and I can give you my own. I do RP because theoretically it has a less wear. So an all younger active patient gets RP in our hands. Younger defined as 60 year and younger. 60, 65 old doesn't make too much difference.
Chid, I was surprised by your numbers about running. I find in my own practice, patients with hip surgery are capable of running. Patients with knee surgery, knee replacement, have a hard time running. Playing tennis is different than being a runner.
Yeah, it is amazing that you're right. In general, the hip patient are much more active, and then that number was about 60% of the hip patients were participating in one or two sporting activity, and in the knee that number was only in 40s. So that's the... Yes, Doug?
Dr. Ranawat, this is a 56-year-old who's active and heavy. I noticed that you resurfaced his patella. I was curious on the panelist, assuming that it looked like on the lateral that he did have some degree of patellofemoral arthritis, but if we were to make the assumption the same patient didn't have significant patellofemoral symptoms, would it be reasonable to leave it unresurfaced?
Yeah. Why don't we keep that topic for tomorrow? This is one of the topic for tomorrow discussion, a debate, I should say.
Actually, it's in a half an hour.
Okay, so we'll leave it for that session, and we will argue at that time. I can give my opinion. I replace all. And there are people who replace none, and there are people who replace selectively. So that's the spread among us, among probably here too. So that's those are the facts in life. Okay. Here is another patient who is 65 and a painful knee for many years, and she is progressively disabled. So we start, Doug, from your end. Why patients with the valgus deformity do not come to doctors earlier than the medial side? Do you have any observation on that?
I agree with your observation. It amazes me that they're always coming at a much later stage in terms of their disease. I'm not sure if some of the valgus disease pattern is offset by some of the gait pattern that they might have. Maybe there's a slight adduction moment that may offload it a little bit while they're walking. I'm not exactly sure, other than the fact that I share your similar observation that they arrive later. In this case, Chid, I just want to be sure about one thing. This is a non-inflammatory condition? That's a question.
Say again?
Is this an inflammatory or non-inflammatory?
Osteoarthritis.
Osteoarthritis.
Any of the panelists wants to offer an explanation why valgus knee patient come later than varus knee?
We have a lot of patients with rheumatoid, with a lot of valgus.
No, rheumatoid, I'm not talking rheumatoid.
But there is a relevance in this, and the relevance is that most of those patients are more frequently visiting the rheumatologist than the varus knees.
No.
And that is why they tend to be kept under local treatment for quite long.
Don't blame the other doctors. Don't blame the other doctors, because they're not here to defend. Okay, let me give you the observation, which I have been looking at this matter for a long time. Valgus deformity creates a more congruous lateral femoral condyle. So it is more congruous, does not have an edge loading. And that's the reason they do not hurt as much. Their main complaint is instability and difficulty in walking on an uneven ground. Therefore, they wait a long time before they come. Varus knee start getting, as the load axis goes out of the joint, they start edge loading, and therefore per square centimeter the load seen by the bone is a lot greater because the surface area is smaller. Yeah. Ted?
Just one other point too. I'm not sure if it's true in Indian society, but in North America, women present at a later stage with more disability for knee replacement than men.
Yeah, but that's in general for medial or lateral. Woman endures pain better than men, and that has been shown by labor pains. So men doesn't have it, any kind of pain. So they are tough in general. Are there any issue in the middle, Dr. Mario, in this valgus knee which you will be worried about?
The usual valgus, we got to check out for the medial ligament, and also keep an eye while you are releasing the lateral side that you take care of the nerve, the peroneal nerve. Those are the two major issues.
I'm sorry, I didn't hear. Could you repeat it?
Yes, I would be concerned about how much is the medial ligament, what is the condition of the medial ligament, and also concerned about the lateral peroneal nerve when I'm actually going to operate this patient.
Yes. The concern on the medial collateral ligament is obvious, that the ligament is elongated.
Yes.
Rarely it is ruptured, it is always elongated. All right. And this is a type 2 deformity, right? That is elongation of the soft tissue sleeve medially. And the type 1, where there is no elongation and you have a valgus deformity as described by Ken Krakow. All right. So what would you do? Start from the other. What would you do? What kind of knee?
I would use a posterior stabilized knee in this case. And the other problem that you'd have to think about is the deficiency in bone. Now, often there's bone deficiency in the tibia. In this case, the tibial deficiency is not great, but there is a very hypoplastic lateral femoral condyle there, which may cause some technical challenges.
So, yes, there will be a bone defect on the lateral tibial plateau. Usually, that defect is a little bit posterior and central posterior. That's the location of these defects. So would you be concerned about putting a wedge or a bone graft or something?
I think in this case, I don't think it would be necessary. But if it were necessary, I would use a wedge.
Yes. It's rare in my hands to use anything on the lateral side because it's a contained bone loss, and therefore after you cut it, it still remains contained. So you just make a drill hole and you fill in with a bone cement. Yes, Steve?
You also asked, what concerns we'd have. I think the one issue in terms of our planning and when I'm thinking these kind of cases through is my provisional initial bone cuts are not aggressive bone cuts. And I think that, if you go and do your standard reference and you now take 10 millimeters of bone off that tibia, you're going to have a huge flexion extension gap. Same thing on the femur. Usually we reference the intercondylar notch, but in some of these knees, you're just taking a whiff off the distal lateral femur, and that's okay to start with that.
That's an excellent point, and which I already emphasized in my technique, that any time you have varus or valgus and opposite side elongation, which is here, you measure that elongation, and my measurement roughly here is 5-6 millimeter of medial collateral is elongated. So you have to compensate, let's say 5 millimeter. So I'll cut 2-3 millimeter less on the tibia and 2-3 less millimeter on the femur. So I'll maintain the joint line, and I would not have to put an insert bigger than 10 millimeter if I follow that rule and elongate the lateral structure appropriately. All right. The often feared complication is nerve palsy in valgus knee. How real it is. And let's start with Ted.
Well, I think it's something that was dealt with in the early literature where a fixed deformity more than 20 degrees was deemed something that needed a perineal nerve release, and subsequently surgeons have not been doing perineal releases except in the most extreme cases. This combination of flexion and valgus is probably the most extreme case, probably the only case where I would consider a perineal nerve release.
Those what he just mentioned, some surgeon did it. We were those some surgeon, me and John Insel, and we wrote that paper, and we summarized by saying that when we explored the nerve to prevent the nerve palsy, the incidence was higher, not lower. So we gave that up, and it's published in JBJS. The first author is Howard Rose, and me and John are the second and third author on that paper. And the incidence was 0.27% of nerve palsy following total knee. So the moral of the story is the high-risk group of patients who gets the nerve palsy, and Ted's statement is correct, is flexion valgus deformity. But exploring the nerve to prevent it was not shown to be beneficial. It was actually harmful. Yes?
I was going to say, too, you asked, is it a real entity? I think it's a real entity. Obviously, we talk to our patients and say the chances are higher in this kind of knee than in a varus knee. But I think in the releases you've discussed and Amar discussed, and we all do, the slow, steady release, you're not forcing it and cranking it. And some of these, we didn't mention it, but some of these, although come in like this weight-bearing, are passively correctable to neutral. And I think the chances are minimal in those cases. It's when it's a fixed 30 degrees and you're struggling to get it around.
That's what Amar showed in his talk, one which was a 30-35 degree of valgus, which was correctable to neutral. That's different than a person who has this and doesn't buzz. For sure. So remain in that position. So there are two different in terms of difficulty in balancing the soft tissue sleeve. All right, so that's what we did. So we were... The reason I did a mobile bearing again on her, that we were testing the mobile bearing knee as it was introduced in 2001. So we did close to 800 consecutive mobile bearing knee in all comers. So that was our way of doing then. But if I were to do it now, we will do a fixed bearing knee at that age and for this deformity. And as you could see, we put the 10 millimeter insert, so we cut a less amount on both sides. Yes?
The other thing to mention with this knee that nobody has mentioned yet is they may be would be a good candidate for a lateral approach because you probably have to do a lateral release on the patella anyway.
All right. That's another controversial issue in a valgus knee, whether you go lateral or you go standard medial parapatellar. Let's see on the panel. Raise your hand, those who would do lateral side. One. So you are in minority.
Can I make a comment? We use the lateral approach.
And so let me, I give you an opportunity. Why, Doug, why is that more people don't use lateral when there are all the benefits claimed to go lateral?
I would say that the most important thing is just to use the approach that you're most familiar with. This is all about visualization, as you've taught us all, and to become familiar with performance of the operation. So I think you can accomplish all of the goals necessary to have a successful knee replacement using a medial parapatellar approach.
Yeah.
So that's what I'm familiar, and that's what I would do.
Yeah. The argument given by the lateral side, which we'll hear in a minute, all right, well, tell us the reason for.
It's only if you if the patella is lateral, and you will definitely need a lateral release. We don't do it for valgus knees, but if the patella is lateral and you will need an extensive lateral release, then if you do your approach lateral to the patella, you already have the release of the patella, and you don't have to have.
So you have assumed that you have to do a lateral release in these knees, and I would defer. We don't do any more formal release even for this kind of deformity. The most we do is pie crusting to just get a little more elongation of the vertical height of the tight IT band. We don't do any more formal release for any kind of knee. And that you avoid that if you cut the tibia right and the femur right and size it properly and lateralize the component correctly and rotate it properly. So there are 4 elements I described when you do that. The other thing is, what's about the tibial cut in a valgus knee? Here it came about degree or 2 of varus. So if you were, even the navigation people will say this is an outlier because the tibial cut is in varus of 2 degrees or 3 degrees. And I say to them, in valgus knee, it has to be 2-3 degrees of varus. If it is not, your correction will be under-corrected. And the reason this happens is there is a valgus remodeling of the whole diaphysis in these patients. So ankle has to be horizontal, and therefore this has to be into varus to bring it parallel. So you are compensating the diaphyseal deformity at the tibial cut.
Yeah, I mean, the other word you're saying is this is just because it's a cone down radiograph, it looks like this, right? A standing hip to ankle view would have a neutral mechanical axis, and that would be 90 degrees to the long axis of the tibia, but it's just because you're looking at this cone down view.
That's correct. Okay. Who else want to criticize? There is one thing which is not good on this X-ray. Yes, Doug?
With all due respect, you didn't leave that cement there on purpose, did you?
That's correct. There is a piece of cement on the lateral gutter, and another patient who is 57 and has a biplane varus and flexion deformity, and he is also an active golfer. Now the question will come, would you let him play the golf the way he wants to play if you got a good knee? So this knee is no different than the first knee in terms of complexity of correction. the question I'm asking the panelists start from Doug, your side. Now, when do you say don't play golf? And what are the forces in driving the golf ball?
I think the forces vary as to your level of competency. I think what you're getting to, and I think the work that Cliff Caldwell did using the telemetrized knee it certainly enlightened me as to the magnitude of the forces that are put on the knee during the golf swing. And having said that, however, I would not dissuade my patients from playing golf.
Yes. The golfers in general, when they hit 60s, and if they are playing golf for the last 15, 20 years, they have an addiction to the golf. And even if you say don't, if he can, he will play the golf. Yes, Dad.
Just 2 points on golfers that Bill Mallon actually studied them, and when they have their total knee replacement, their driving distance does not improve.
Yeah.
That's number one, and many of them will report aching in their knee after walking around a golf. So golf is a reason that a lot of people have their knee replaced, and they need to know what to expect.
Yeah, I think the golf, driving the ball, creates anywhere from 3 to 5 times body weight magnitude when you're driving the ball from the tee. So enormous forces are generated. So here is a fixed bearing knee, and this knee I like to have a commentary, and I started with Steve. Steve, you gave a radiographic criteria of a well-aligned tibial cut, femoral cut, positioning of the component. So run down one more time and taking this x-ray, critique it, what is good, what is not good.
So I'll start with the tibia. So first look at sizing, and it looks well sized, doesn't look particularly overhung. I think probably when you did that, you took quite a bit of the medial fights off, based on the preoperative radiographs. The other thing I like to look for, which I didn't mention, if you look at the cement mantle, see how you've got the cement mantle down in the IM canal? I look for that in each knee, and it's been controversial in the past whether you should cement right down in that, and I don't think there's any doubt in my mind. There's 2 RSA studies that have looked at micromotion. We haven't talked about that today, but I think that's an important point we haven't emphasized, is when you cement, you don't cement the surface, you cement down the canal. And the way this preps, it actually creates like a little bone plug where you can inject and pressurize. I don't know if you have a comment, but you did that on purpose.
Yeah. I think the Descartes was one of the first one to propose just cementing the top and not cementing the keel. And I say cement the keel. And that was the argument between me and Peter Walker when we designed the total condylar. I say, I want a stem. He said, no, you don't need a stem. And tibial bone is good enough and 2 pegs are good enough. I say, no.
Yep.
If the stem doesn't get loose in the femur, I need a stem in the tibial too. That was my reasoning. So that's how we put the stem on total condylar. And if you have a stem, you should cement it. If you don't, in 10 years, about 10% get loose. There are 2 studies on that subject. Yeah. So you should be aware.
Looking at the femoral component quickly, you've lateralized well, which is one of the points we've all made. Yeah. I think if you look at the congruence between the polyethylene and the femur, it's well balanced. I think when you first have a quick glance at that, you might say in your brain, there's a femur undersized. And I think it shows a classic where every femur is not always the same in terms of what you get AP versus ML. And so that's an intraoperative balancing issue. And so, I never sort of comment on does the femur look oversized, yes, you can see on the lateral, sometimes on the AP. Yeah. You can't tell undersized because that's an intraoperative call and sizing.
If you correctly measure the flexion space in a man on an AP, the femur should look undersized. Mm-hmm. Because the man femur is wider medial laterally and shorter front to back, opposite to the woman, where it is proportionately more front to back than medial to lateral. So X-ray will often look like this, that
Exactly.
it looks undersized
But it's not.
on AP. Okay. All right. This is a little more challenging, and we start in the middle this time. Dr. Maria. Patient, he is from India actually, and he had an open fracture from a motorcycle accident and had a malunion, as you could see, in proximal tibia, and ended up with this big deformity. So, what are the challenges you have?
Well, obviously there is a considerable amount of varus here, and you would find that there has been a malunion in upper tibia.
If you want to know, it was 34 degrees.
Oh, okay.
I can give you the number.
Yes, I mean, I would be happy to see a slightly longer X-ray to see from top to bottom how it's going.
Take
But
my word, it is 34 degrees on a
Right.
long film.
Fair enough, accepted. Yeah, so, well, obviously, he's 69, he's definitely uncomfortable, and he's going to need replacement. And I think in this particular situation, we should be able to correct it by intra-articular correction and proceed with cruciate sacrificing, if there is a cruciate at all, knee replacement.
So, at what amount of varus you become concerned for the maintenance of the soft tissue sleeve of the superficial medial collateral ligament?
Well, I mean, technically 30, so you're just about 34. So in this case, I'd stretch it a bit. So maybe around 30 degrees would be my alarm bells, because up to 30 we find them very commonly, and our practice, we are able to correct most of them.
Steve, you presented the correction of the extra-articular deformity. What is your take? At what degree you will start thinking of doing something different?
Probably a little bit less than 30. I mean, in all honesty, it could be our bias experience in North America. We don't get a lot of patients coming in at that. But I would say closer to 25 degrees would be where I'd be starting to think of perhaps needing to do a little bit different technique, a little more cut, maybe constrained, like all the things that go through our mind, as having available to me in the OR, as a backup.
Yeah. The deciding factor is this, that I have drawn this line. I will draw another line to the mechanical axis of the tibia like that, and from here to here, if that distance, I'll keep 20 millimeter, because that's the 10 millimeter insert based on the lateral soft tissue element, and then I'll release here completely, free body. And when you do that, you can correct most of the varus or valgus which are close to the joint which it is. And I will put a TC3 device, and this is what I did. So I went for 10 and I ended up with 12.5, as you could see here.
Just a quick question. Did you go through a thought of perhaps cementing in a short stem on the tibia, using a constrained? What's the reason to, what's the driver to not do that?
Yeah. The question is, do you want to use a stem for TC3 device? That's the question. And there are 2 studies which shows that you don't need it. and there are other studies which show you do need it. And I have gone both ways. Here I chose not to, because if I do use, I will compromise the cortex on the lateral side.
But assume, okay, and I agree with that. You look at that, and that'd be you'd have to do the smallest tibia, cemented tibia. But assuming you don't have that, I guess just for educational purposes, there's probably not a downside to doing a short cemented stem when you're using a constraint. Is that reasonable?
Yeah, I think if you have an opportunity to use a stem without 30 more millimeter, it's a better fixation and better load distribution. So there should be no argument on that. But if you are trying to achieve that, if you break the cortex here, that will not be a good thing which will be there. So that's the reason.
Can I ask you a question?
Yes.
As you see on the X-ray, the fibula head.
Say again?
The head of the fibula, the tip of the fibula is above the joint line in this primary procedure. Is it?
You see a little bone there on the. So the cut on the tibia, his fibula is high, as you could see prior. So I didn't cut any more tibia. It's just the fibula looks higher than the tibia. Patient was born that way.
But isn't it due to the varus in the knee?
No.
Varus in the tibia?
It's just the variation. The tibiofibular joint is invariably below the articular surface of the lateral tibial plateau in most patients. But there are outliers when it is equal or higher, which is here. This patient is.
Because of the metaphyseal fracture, it probably used to hold.
Yeah, it looks like a Schatzker 6. Yeah. It looks like both condyles were involved. It's like a Schatzker 6 type injury originally.
That's another explanation. Okay.
Can I just make a quick comment on that? The other thing that wasn't mentioned is with a history of fracture, and I think you said it was an open fracture, there's a higher risk of infection in this case. So if you didn't normally use some antibiotics in your cement, you may be...
I think if you have an open fracture alone, that's not a risk. If you had an established bone osteomyelitis, and in those patients, if you do total knee or total hip, the risk for infection is
high.
How much? And where is the documentation of that? Is 2 times to 3 times higher than primary, and this data was collected by Mayos over last 30 or 25 years, and they have published on this topic. So the risk of infection is higher 2 to 3 times in a bone which had an established infection sometime in the past. Okay, let me go to here. This is a patient who had also an open fracture when he was young, and then it became infected, and they did multiple procedures as evidenced on the fibula, but he healed and has remained healed for last 30 to 40 years. And he has one more problem which you want to know, which is a bow in the tibia and patella baja. And one more, okay, I gave you the clue, but here the bad hip on the same side. So this is a complex deformity, as you could see, in the tibia. And choices you have is, who wants to take? Dr. Maria?
You want to know what I'd do? I'd refer him to you, basically. That would be the safest bet. Yes, obviously we are going to have a lot of stiffness here, and I would have perhaps thought differently, but for the fact I've seen the next X-ray, and in which case I would be more concerned about also the bowing. Maybe I try to...
My question is, would you do an osteotomy of the tibia or not? That's the question. The rest is, you can't change the patella baha and rest the risk of infection you can't change.
I personally would like to, even though I've seen the film, but I'd like to.
Yeah. I've done this several times in a patient who has the bow, anterior bow, up to, and I template it and I judge it. If I can do it without osteotomy, I would do. And that's what I did here, so I can show you what I did. This tibial cut is parallel to the ankle in this plane. So I corrected the deformity that way. So in the AP he looks, as you could see, perfectly well aligned. But if you cannot, the next choice is osteotomy here and use a rod to fix it. I think our time has run out on the knee cases, and so I want to thank the panelists for their job well done, and the audience.